Hello, this is Professor Capron, and today we are going to look at arterial blood gas studies. By the end of this presentation, you will be able to define what an arterial blood gas ABG study is and identify its key components, describe the clinical indications and contraindications for performing an ABG, interpret basic ABG parameters, including acid base balance and compensatory mechanisms, detail pre procedure, intra procedure, and post procedure nursing interventions for ABG collection, educate patients about the ABG procedure, preparing them for what to expect, recognize potential complications of ABG collection, and outline appropriate nursing actions. You'll also be able to apply crisis management protocols specific to ABG complications. Arterial blood gas, or ABG studies, serve as a vital diagnostic tool in healthcare settings, providing a detailed snapshot of a patient's respiratory and metabolic status. They are critical for evaluating oxygenation levels, ventilation efficacy, and acid base balance in the body. Their importance escalates in critical care settings, emergency departments, and for patients on mechanical ventilation. ABGs are essential for clinicians when it comes to making informed decisions regarding treatments such as oxygen supplementation, mechanical ventilation adjustments, or administration of medications like diuretics or bicarbonate. They help in detecting life threatening conditions like respiratory failure, severe infections, or acid base imbalances that could lead to organ failure. The utility of ABGs extends beyond just respiratory or critical care. Surgeons, anesthesiologists, and even general medicine practitioners find them useful for preoperative evaluations and postoperative care. They are also utilized in managing conditions like renal failure, diabetic ketoacidosis, and severe trauma. ABGs are often repeated at different intervals to gauge the effectiveness of treatment modalities. For instance, changes in ventilator settings can be guided by real time ABG findings. Similarly, in a patient with sepsis, persistent metabolic acidosis despite fluid resuscitation may necessitate more aggressive interventions. In diseases like COPD, heart failure, or various forms of shock, ABGs can serve as prognostic markers. Parameters like partial pressure of O2 and partial pressure of CO2 can be predictive of survival rates and can help triage patients in emergency situations. In life care situations, ABGs aid in decision making by providing objective data. They can inform discussions with families about the extent of interventions to be taken or withdrawn, aiding in ethical medical practice. The systematic documentation of ABGs, especially in critical scenarios, serves a legal purpose. It substantiates clinical judgments and can protect healthcare professionals from potential legal implications in case of patient complications. Description of arterial blood gas studies. An arterial blood gas study is a diagnostic test that specifically measures concentrations of various components in arterial blood. This blood sample provides real time insights into the patient's immediate physiological condition. This test assesses five main parameters, each giving its unique set of clinical information. pH measures acidity or alkalinity of the blood. PaO2, or partial pressure of oxygen, examines how effectively oxygen moves from your lungs to your blood. PaCO2, or partial pressure of carbon dioxide, checks carbon dioxide waste removal from the blood. HCO3, bicarbonate, evaluates the buffering capacity to maintain pH. And SaO2, or oxygen saturation, shows the proportion of available hemoglobin carrying oxygen. To obtain ABG, blood is directly drawn from an artery, usually the radial artery. A fine, hollow needle punctures the artery, and a small amount of blood is collected into a pre-heparinized syringe. Immediate analysis is required for accurate results. The importance of rapid analysis can't be stressed enough. Delays can cause gas levels to change, invalidating the results. The ABG test is not a routine screening test. Rather, it is most often ordered as a response to an emergency or during the treatment of a critical medical condition. Though the radial artery is frequently accessed, there are alternative arterial sites available if necessary, including the femoral and brachial arteries. Sterile technique is non negotiable to mitigate the risk of introducing bacteria into the bloodstream. Strict adherence to sterile procedures is obligatory. Now let's look a little more closely at the different components of an ABG. Let's start with pH, which is potential of hydrogen. This is a measure of the acidity or alkalinity of the blood. The normal range is 7.35 to 7.45. pH helps in identifying acid base imbalances. Variations can be life threatening. Low pH indicates acidemia. High pH indicates alkalemia. Both conditions require rapid intervention. PaO2, or partial pressure of oxygen, measures the amount of oxygen in arterial blood. The normal range is 75 to 100 millimeters of mercury. PaO2 helps to evaluate the body's ability to pick up oxygen from the lungs. Low PaO2 indicates hypoxia, necessitating immediate oxygen therapy in most instances. PaCO2, or partial pressure of carbon dioxide, addresses how effectively the body eliminates CO2. The normal range is 35 to 45 millimeters of mercury. This provides insights into respiratory function and, indirectly, acid base status. Elevated PaCO2 could mean respiratory acidosis, while decreased levels suggest respiratory alkalosis. HCO3 is bicarbonate. It acts as a buffer to help maintain a stable pH. Normal range, well, okay, you're going to see different normal ranges. Generally, you're going to see 22 to 26 milliequivalents per liter. Per ATI, the number you need to know are 21 to 28 milliequivalents per liter. The clinical relevance is this aids in diagnosing metabolic imbalances. Low levels signify metabolic acidosis, and high levels indicate metabolic alkalosis. SaO2 is oxygen saturation. This reflects the percentage of oxygen-saturated hemoglobin relative to total hemoglobin in the blood. Normal range is 95 to 100%. This helps to assess the oxygen-carrying efficiency of the blood. Levels below 90% are generally considered hypoxic and definitely require oxygen supplementation, except in specific cases. When we look at correlation among the components, well, no component operates in isolation. The interplay is complex and crucial for correct diagnosis and treatment. For instance, a low PaO2 and a high PaCO2 often occur together in cases of respiratory failure. So the real value of an ABG lies in your ability to swiftly interpret these parameters to make instant clinical judgments. Remember, each component provides a piece of the puzzle in understanding a patient's complex physiological state. Therefore, it's critical to consider them collectively for comprehensive patient management. Indications for the procedure. Now let's look at some of the clinical indications for performing ABGs. The first is respiratory distress or failure. Whether it's a sudden onset of difficulty in breathing due to an acute episode, or a gradual increase in respiratory discomfort related to a chronic condition, ABG is a diagnostic tool of choice. ABG allows for the assessment of the patient's oxygenation status, acid-base balance, and carbon dioxide levels, helping clinicians evaluate the severity and underlying cause of respiratory distress or failure. If results show hypoxia, low PaO2, and hypercapnia, high PaCO2, these are indicative of possible respiratory failure. Immediate intervention, such as the initiation of mechanical ventilation or BiPAP, may be required to stabilize the patient. Severe trauma or surgical patients. For patients who have undergone significant physical trauma or major surgical procedures, ABG testing is vital for immediate postoperative or post-injury assessment. ABG testing provides clinicians with valuable data regarding oxygen delivery to tissues, tissue perfusion, and overall metabolic state, which is crucial for immediate decision making. If results indicate low PaO2 or high PaCO2, Medical interventions like fluid resuscitation, blood transfusions, or supplemental oxygen therapy may be urgently required. Monitoring effectiveness of treatment. In patients already under specific therapies, such as mechanical ventilation for ARDS or medication regimens for COPD and pneumonia, ABGs serve as a regular checkpoint. It provides quantitative data on the effectiveness of current treatments, helping clinicians tweak therapeutic plans and ventilator settings to maximize positive outcomes. Should the ABG results show that the treatment is effective, for example, persistent hypoxia, modifications like changing ventilator settings or switching medications may be immediately necessary. Acid base imbalance diagnosis. When dealing with conditions that inherently or potentially disrupt the body's acid base balance, like diabetic ketoacidosis, sepsis, or acute renal failure, an ABG is indispensable. It offers a rapid, reliable way to assess systemic pH levels, bicarbonate concentration, and compensatory mechanisms, all of which are crucial for diagnosing and treating acid base imbalances. Depending on the ABG findings, immediate interventions like bicarbonate administration for acidosis or prompt dialysis for renal failure may be initiated. Unexplained tachycardia or hypertension. When a patient exhibits elevated heart rate or blood without a clear precipitating factor, ABG can be a useful diagnostic tool. Tachycardia or hypertension may be compensatory mechanisms for underlying hypoxia or hypercapnia, and an ABG can help confirm or rule out these possibilities. If the ABG results confirm hypoxia or hypercapnia, immediate measures such as oxygen supplementation or pharmaceutical interventions like beta blockers can be undertaken to manage the symptoms. Toxic substance exposure. In cases of suspected toxic exposure, such as carbon monoxide poisoning or cyanide ingestion, ABG can help to evaluate the severity and guide treatment. It assesses the impact of the toxin on respiratory and metabolic functions by measuring PaO2, SaO2, and other parameters. If exposure to a toxic substance is confirmed by low PaO2 and SaO2, treatment like hyperbaric oxygen therapy or administration of specific antidotes should be commenced immediately. Monitoring in critical care settings. For critically ill patients in ICUs or specialized care units, such as postoperative or sepsis patients, ABGs are routinely performed for close monitoring. The test gives a comprehensive view of the patient's current respiratory and metabolic status, enabling real time adjustment in medical interventions and supportive care. Could the ABG show alarming results, such as falling pH levels or rising PaCO2, rapid adjustments in treatment plans need to be happened. Fluid resuscitation or life support measures will be urgently made based on these findings. By recognizing these clinical indications for ABGs, nurses can not only contribute to quicker diagnostic processes, but also take part in immediate interventions that can be. Let's look at some precautions and contraindications. One of these is anticoagulant therapy or bleeding disorders. Patients receiving medications like warfarin, heparin, or if they have clotting disorders like hemophilia, are at a significantly higher risk when it comes to arterial punctures. The puncture in arterial walls may not seal naturally after the procedure, which could lead to severe bleeding and hematoma. Moreover, clotting factors required to cease the bleeding may be insufficient or impaired in these patients. If you still require data similar to ABGs, consult with a physician for alternatives. Pulse oximetry or end tidal CO2 measurements may be suitable, although these methods provide limited information in comparison to a full ABG analysis. Always weigh the risk and benefits critically and consult the interdisciplinary team. Severe peripheral vascular disease, especially conditions like advanced atherosclerosis or Raynaud's phenomenon, can seriously compromise arterial blood flow in the extremities. Introducing an arterial puncture in an area with poor vascular supply can lead to tissue ischemia, necrosis, and worsen the patient's peripheral vascular condition. Non-invasive methods such as venous blood gases or pulse oximetry may be employed as surrogate measures of oxygenation and ventilation. especially when ABGs are not absolutely mandatory for clinical decisions. Recent surgery at the puncture site. If a patient has recently undergone vascular or other related surgeries close to the common sites of arterial puncture, these sites should be avoided. The tissue at the surgical site is already compromised, and puncturing it may exacerbate the healing process, introduce infection, or cause surgical dehiscence. Consider using an alternative site for arterial puncture, or, if possible, opt for non invasive methods like pulse oximetry to obtain necessary data. Infection at the puncture site. Any signs of skin infection like cellulitis, abscess, or other localized skin conditions at the potential puncture site warrant caution. Puncturing through infected tissue can introduce bacteria directly into the bloodstream, posing a risk for systemic infection or sepsis. Consult with the interdisciplinary team, which may include infectious disease specialists, to select an alternative puncture site or to decide on non invasive monitoring methods if the arterial blood gas information is not critically necessary. Each of these points offers not only a reason to avoid ABG, but also provides a broader context, underlying scientific rationale, and potential alternative actions to take. This equips you to make sound clinical decisions. Now let's look at some scenarios that necessitate ABG analysis. Acute respiratory distress syndrome, or ARDS, is characterized by a rapid onset of hypoxemic respiratory failure. When a patient is presenting with severe shortness of breath, low blood oxygen levels, and infiltrates on chest x ray, an ABG is pivotal. The ABG provides information on how effectively the patient is oxygenating and ventilating, which is crucial in determining the immediate therapeutic strategy, such as intubation or initiation of positive pressure ventilation. Promptly conduct an ABG analysis, and if a PaO2 FiO2 ratio is less than 300, immediate management for ARDS should be initiated. Sepsis accompanied by organ dysfunction usually results in altered physiological parameters, including abnormal blood gases, acid base imbalances, elevated lactate levels, and abnormal oxygenation may occur. ABGs can guide resuscitative efforts and determine the need for advanced life support measures. ABGs are crucial for assessing the severity of sepsis and determining whether interventions like vasopressor therapy or mechanical ventilation are necessary. Patients who have consumed amounts of drugs, such as opioids, benzodiazepines, or barbiturates, may have respiratory depression, which can lead to life threatening acid base imbalances. ABG assessment will reveal whether the patient is suffering from respiratory acidosis due to hypoventilation or if other metabolic derangements are present, guiding prompt intervention. ABG results in this scenario can expedite the decision making process for antidote administration or the initiation of respiratory support mechanisms like ventilators. Acute pulmonary embolism, or APE, is an acute vascular occlusion in the lung that leads to sharp decline in respiratory function and gas exchange. ABGs can confirm hypoxemia and can help differentiate between APE and other conditions that present with similar symptoms, such as acute myocardial infarction or pneumonia. An ABG result PaO2 and high PaCO2 in the context of other clinical signs warrants immediate actions like anticoagulant therapy and possible surgical intervention. Acute exacerbations of asthma or COPD can rapidly lead to respiratory failure. ABGs offer a precise and timely measurement of the severity of the airflow limitation and can indicate if immediate hospitalization or even intubation is required. If ABG shows severe acidosis and elevated PaCO2 levels, immediate respiratory support should be initiated, potentially including intubation. Each of these scenarios not only outlines why an ABG is necessary, but provides clinical context, the underlying physiological mechanisms at play, and the immediate nursing actions required to manage these critical situations effectively. Interpretation of findings. When we're looking at respiratory and metabolic imbalances, we need to be able to differentiate between the two. Accurate diagnosis of the underlying condition is pivotal for effective treatment. Misinterpretation can lead to incorrect treatments and further imbalances. For example, mistaking respiratory acidosis for metabolic acidosis and treating with bicarbonate can exacerbate the patient's condition. Some key markers for differentiation: PaCO2 levels. Elevations here generally indicate respiratory issues. Look for PaCO2 levels higher than 45 millimeters mercury in respiratory acidosis and lower than 35 millimeters mercury in respiratory alkalosis. And then there's HCO3 or bicarbonate levels. Deviations signify metabolic issues. Check for HCO3 levels less than 21 milliequivalents per liter in metabolic acidosis and greater than 28 milliequivalents per liter in metabolic alkalosis. When we're assessing pH, acidic pH levels less than 7.35 direct you towards acidosis. Alkaline levels greater than 7.45 indicate alkalosis. If the pH and PaCO2 are inversely related, it's likely a respiratory issue. If the pH and bicarbonate are moving in the same direction, suspect a metabolic issue. Respiratory imbalances often have quicker onset and resolution because lungs can adjust rapidly. But metabolic imbalances typically take longer to develop and to resolve, requiring renal system intervention. We also need to look at compensation. Respiratory compensation. Observe if bicarbonate is moving opposite to the direction of pH and PaCO2. This typically takes hours to days. Metabolic compensation. Look for PaCO2 changes in the opposite direction to pH and bicarbonate. This is faster, often occurring within minutes to hours. So, for our diagnostic tests, let's look at serum electrolytes. Abnormalities in potassium, sodium, or chloride can give clues toward metabolic imbalances. Or chest x ray or CT is useful in assessing respiratory conditions like pneumonia or pulmonary edema, which could lead to respiratory acid base imbalances. Let's look at understanding compensation mechanisms. Compensation is the body's attempt to correct acid base imbalances by engaging either the respiratory or metabolic systems. It's crucial to recognize whether the body is compensating, as this impacts both diagnosis and treatment strategies. There are three types of compensation. First, there's uncompensated, no compensation. This means there's no evidence of efforts by the body to normalize the pH. Only one parameter, either PaCO2 or bicarbonate, is abnormal, along with an abnormal pH. For example, in acidosis, pH and PaCO2 are abnormal, but HCO3 is within the normal range. If it's partially compensated, the body is attempting to correct the imbalance, but the pH is still abnormal. All three parameters, pH, PaCO2, and bicarbonate, will be abnormal. For example, in metabolic alkalosis with partial respiratory compensation, you'll see elevated pH, elevated bicarb, and also elevated PaCO2. If the body has successfully corrected the pH to a normal range, though PaCO2 and HCO3 may still be abnormal, that's called fully compensated. Here it's crucial to look at which value, PaCO2 or HCO3, has moved in the opposite direction of its normal range to correct the pH. For example, in compensated metabolic acidosis, pH returns to normal, but both HCO3 and PaCO2 are low. Respiratory system's role in compensation. While the respiratory system is quick to react, capable of altering ventilation within minutes, it alters PaCO2 levels by changing the rate and depth of breathing. The metabolic system, however, is slower to react, taking hours to days to adjust. The kidneys modulate bicarb levels through renal absorption or excretion. We need to interpret compensation with the tic-tac-toe method. Use the tic-tac-toe method to help recognize the type of compensation. Place pH, PaCO2, and HCO3 each in a box. The box that has two values signifies the primary imbalance, and the lone value indicates the compensatory action. Clinical implications of this. Compensation status can inform the urgency and type of intervention required. Partially compensated cases generally demand more immediate attention compared to fully compensated cases, which may be managed more conservatively. Before we start looking at this decoding acid base balance slide, I recognize that the reference ranges listed here vary from many other online sites. These are the reference ranges in the latest edition of the ATI Medical Surgical Nursing book, which means these are the ranges that the students in my classes will be tested on. Let's look at the tic-tac-toe method, an overview. First, draw a tic-tac-toe grid on a piece of paper. Label the columns as pH, PaCO2, and HCO3. This grid will serve as a visual aid to categorize your ABG values and streamline interpretation. Now let's start placing ABG values in the grid. Place the actual pH, PaCO2, and HCO3 values in the appropriate squares. For example, a pH of 7.25 would go in the acid row under the pH column. Compare these values to the normal reference ranges, pH 7.35 to 7.45, PaCO2 35 to 45 millimeters mercury, and HCO3 21 to 28 milliequivalents per liter. Accurately categorizing values ensures a correct interpretation. Now identify which row has at least two values placed in it. This indicates whether you're dealing with an acid or alkali imbalance. Two or more values in the same row signify the primary nature of the imbalance. Identify which of the two values align. Is it PaCO2 with pH or is it HCO3 with pH? If PaCO2 aligns with pH, the issue is respiratory. If HCO3 aligns with pH, the issue is metabolic. Knowing the origin helps direct your nursing interventions. Then check the third value in your tic-tac-toe grid, the one that did not align with the first two. If this value moves in the opposite direction of the pH, then compensation is occurring. Recognizing compensation is critical for understanding the severity and for planning further care. Validate the tic-tac-toe findings with the patient's symptoms, history, and other diagnostic tests. This step ensures that your interpretation aligns with the patient's overall clinical situation, guiding your subsequent nursing actions. This tic-tac-toe method offers a structured, visual approach for interpreting ABGs. By following these steps, you'll be well equipped to quickly and accurately understand a patient's acid-base balance, enabling timely and effective nursing interventions. Now let's start looking at some examples of decoding acid-base balance. Here's our first practice problem. You have a pH of 7.46, a PaCO2 of 30 millimeters of mercury, and an HCO3 of 20 milliequivalents per liter. Pause the video and try to figure out the acid-base balance. Now let's look at this problem by placing the answers on the grid. So we have 7.46, that's alkali for the pH because it's greater than 7.45. We have PaCO2 of 30, that is less than 35, so that is also alkali. Recognize that although they're on the same line, they are moving inversely. The pH is high and the PaCO2 is low. Then we've got the bicarb up there with 20, which is in the acid low. So we've got respiratory alkalosis with a partial compensation. The possible clinical scenario is an early stage of high altitude sickness. Let's try another one. In this practice problem, you have a pH of 7.50, a PaCO2 of 40 millimeters mercury, and an HCO3 of 32 milliequivalents per liter. Pause the video and try to figure out the acid-base balance. Okay, so let's place everything on the chart and look at what we have. Our pH is 7.50. That is greater than 7.45, so we are alkaline. We are dealing with some form of an alkalosis. Our PaCO2 is normal. At 40, it's well within the range. Our HCO3 is 32, which is also in the alkaline category because 32 is greater than 28. So with pH and bicarb in alkali and PaCO2 in normal, we have metabolic alkalosis with no compensation. A possible scenario that could cause this is excessive vomiting, causing a loss of stomach acid. Let's try another practice problem. Here, your pH is 7.32, your PaCO2 is 52 millimeters mercury, and your HCO3 is 29 milliequivalents per liter. Pause the video, try to figure out the acid-base balance. Okay, so let's put everything on the chart and see what we have. Our pH of 7.32 is less than 7.35, so that's in the acid column. Our PaCO2 of 52 is greater than 45, so it is also in the acid column. Our bicarb at 29 is greater than 28, so that's down in alkaline. So we have pH and PaCO2 in acid, bicarb in alkali, so we have respiratory acidosis with partial compensation. The possible scenario that could cause this is opioid overdose causing respiratory depression leading to retention of CO2. Let's try another practice problem. In this one, your pH is 7.48, your PaCO2 is 28 millimeters of mercury, and your HCO3 is 24 milliequivalents per liter. Pause the video, try to figure out the acid-base balance. Okay, let's fill out the chart and see what we have. Our pH of 7.48 is greater than 7.45, so that is alkali. Our PaCO2 of 28 is less than 35, so that is also alkali. Our bicarb of 24, well, that's normal, right in the middle of the range. So we have pH and PaCO2 in alkali and bicarb in normal. So we have respiratory alkalosis with no compensation. A possible scenario that could cause this is acute hyperventilation due to an anxiety attack. Let's try another practice problem. For this one, your pH is 7.47, your PaCO2 is 46, and your HCO3 is 34 milliequivalents per liter. Pause the video, try to figure out the acid-base balance. Okay, let's put all of our values on the chart and see what we have. Our pH at 7.47 is greater than 7.45, so that's in the alkaline category. Our PaCO2 of 46 is greater than 45, so that is in the acid category. Our bicarb at 34 is greater than 28 and therefore in the alkali category. So we have pH and bicarb in alkali and PaCO2 in acid. So we have metabolic alkalosis with partial compensation. A possible scenario that could cause this is prolonged diuretic therapy without proper electrolyte replacement. Let's try another practice problem. For this one, your pH is 7.36, your PaCO2 is 50 millimeters of mercury, and your HCO3 is 30 milliequivalents per liter. Pause the video, try to figure out the acid-base balance. Okay, let's put all the numbers on the chart. Now, please notice that pH is normal. 7.36 is a normal pH, but not by much. Look at the arrow. It's really leaning towards the acidic. PaCO2 is definitely acidic, with 50 it being greater than 45. And bicarb is in alkaline, so that's 30 is definitely greater than 28. What do we have going on here? Well, what we've got is respiratory acidosis, but we have full compensation because everything is balancing out to keep the pH in a normal range, if just barely. So, a possible scenario here is a patient with long-standing COPD on home oxygen therapy. Okay, let's try another practice problem. For this one, the pH is 7.30, the PaCO2 is 34 millimeters of mercury, and the HCO3 is 18 milliequivalents per liter. Pause the video and try to figure out the acid-base balance. Okay, let's put all the numbers on the chart. pH of 7.30 is less than 7.35, so that's in the acid category. A PaCO2 of 34 is less than 35, so that's in the alkaline category. And a bicarb of 18 is less than 21, so it is in the acid category. That gives us pH and bicarb in acid, and we've got a PaCO2 that's in alkali. This means we have metabolic acidosis with partial compensation. A possible scenario here is diabetic acidosis before treatment is initiated. Let's try another practice problem. For this one, your pH is 7.44. Your PaCO2 is 48 millimeters of mercury, and your HCO3 is 31 milliequivalents per liter. Pause the video and try to figure out the acid base balance. Okay, let's put all the numbers on the chart. Our pH of 7.44 is normal, if barely. Our PaCO2 of 48 is greater than 45, so that's an acid. And our bicarb of 31 is greater than 28, so that's an alkali. pH in normal, PaCO2 in acid, bicarb in alkali. Notice that our pH is almost alkali, and we have an alkali bicarb. So what we have here is metabolic alkalosis with compensation from the respiratory system. A possible scenario could be chronic use of antacids for gastroesophageal reflux disease. Let's try another practice problem. This one, your pH is 7.43, your PaCO2 is 32 millimeters of mercury, and your HCO3 is 20 milliequivalents per liter. Pause the video, try to figure out the acid base balance. Okay, let's put all the numbers on the chart. Our pH at 7.43 is normal. Our PaCO2 at 32 is less than 35, so that's alkaline. Our bicarb at 20 is less than 21, so that's acid. So clearly we've got something compensated here. So let's look at that pH again. That pH is almost alkaline. So if we have an almost alkaline pH and an alkaline PaCO2, we are looking at respiratory alkalosis with compensation. The possible scenario here is a patient with chronic hyperventilation syndrome who is on long term treatment. Let's try another practice problem. For this one, your pH is 7.37. Your PaCO2 is 32, and your HCO3 is 20. Pause the video, try to figure out the acid base balance. Okay, let's get all these numbers on the chart. 7.37 is a normal pH. 32 is less than 35, so that's an alkaline PaCO2. And our bicarb at 20 is less than 21, so that's an acid HCO3. Our pH is normal, but it's leaning towards that acid. Our PaCO2 is alkali and our bicarb is acid. That means we've got a metabolic acidosis with compensation. The possible scenario here is a chronic kidney disease patient on bicarbonate replacement therapy. Let's do another practice problem. For this one, your pH is 7.28, your PaCO2 is 55, and your HCO3 is 24. Pause the video, try to figure out the acid base balance. Okay, let's get all these numbers on the chart. Our pH at 7.28 is less than 7.35, so that's in the acid category. Our PaCO2 at 55 is greater than 45, so again, in the acid category. But our bicarb at 24 is perfectly normal. So if pH and PaCO2 in acid and bicarb in normal, we have respiratory acidosis with no compensation. A possible scenario for this would be an opioid overdose causing respiratory depression, leading to retention of CO2. Okay, let's do one final practice problem. For this one, your pH is 7.25, your PaCO2 is 40, and your HCO3 is 16. Pause the video, try to figure out the acid base balance. Okay, so we have all the numbers on the charts. Our pH at 7.25 is less than 7.35, so that's an acid. Our PaCO2 at 40, well, that's normal. And our bicarb at 16 is less than 21, so that is also acid. So what we have here with pH and bicarb in acid and PaCO2 in normal is metabolic acidosis with no compensation. Possible scenario for this would be severe diarrhea causing a loss of bicarbonate. Nursing interventions pre-procedure. Okay, so generally speaking, nurses do not draw arterial blood gases. The role of the nurse is critical still to set the stage for an accurate and successful ABG collection. Your preparatory steps directly influence the quality of the data and the safety of the patient, so we need to prepare the patient. The healthcare provider will obtain consent, but you can facilitate this by educating the patient on the procedure's risks and benefits. Often, the provider isn't as good as explaining things as we are. This not only helps in securing informed consent, but also allays any anxieties the patient may have. For positioning, assist the healthcare provider in positioning to provide easy access to the artery and minimize any risks like hematoma. Make sure to document baseline vitals and respiratory status. This initial data serves as a point of reference for identifying any sudden changes post procedure. Make sure to pass the antiseptic solution to the healthcare provider for site preparation, ensuring adherence to aseptic technique. While the healthcare provider performs Allen's test, assist as needed and observe to confirm collateral blood flow. You're also going to have to help with preparing the equipment supply. So double check to make sure that the syringe is heparinized and air bubble free. Alert the healthcare provider if any issues are observed. Don gloves and any other required PPE to uphold stringent infection control standards. Assemble gauze, tape, and a pressure device so they're within arm's reach, facilitating a streamlined procedure. Document. Make sure they confirm that all patient identification details are correctly placed on the specimen label by the healthcare provider, and prepare to annotate any complications or notable patient reactions during the procedure in the medical record. Let's pause for a minute to talk about Allen's test. Allen's test serves as a pivotal procedure to assess collateral circulation in the hand before an ABG collection from the radial artery. Performing Allen's test ensures that if the radial artery becomes occluded post procedure, there is an alternative pathway for blood flow, mitigating the risk of ischemia to the hand. It's a quick and straightforward diagnostic maneuver. It involves the occlusion of both the ulnar and the radial arteries, followed by release of one to check for adequate blood supply. So, here are the steps you need to take to conduct an Allen's test. Watch the patient positioning. Ensure that the patient's hand is at heart level, either resting on a table or holding it up. And explain the procedure to the patient to gain cooperation and ease any anxieties. Use your thumbs to occlude both the radial and ulnar arteries while asking the patient to open and close their hands several times until it appears blanched. That's a white color. Then, while still occluding the radial artery, release the ulnar artery. Watch for the hand to pink up within 5 to 15 seconds, signaling adequate collateral circulation. A hand that pinks up quickly indicates good collateral circulation and gives a green light for radial artery puncture. But if the hand stays pale or takes too long to pink up, an alternative site should be considered. Red flags are a failure to pink up. This indicates poor collateral circulation, contraindicating radial artery puncture at that site. It leads to exploring alternative sites, usually the brachial artery, as a safeguard against ischemic complications. If the hand pinks up but takes longer than that standard 15 seconds, it may be advisable to proceed cautiously or consider another site. Make sure to document the Allen test results meticulously in the patient's chart, indicating whether the radial site on that hand is appropriate for arterial puncture or if an alternative site will need to be used. Your role as a nurse in ABG collection is not hands on in terms of drawing the blood, but it's absolutely critical for patient preparation and assisting the healthcare provider. Proper positioning and site selection are key elements that significantly impact the accuracy of the ABG results. We've got a couple types of patient positioning. You can assist in positioning the patient in an upright or semi-Fowler's position, especially if they have respiratory distress. This improves lung function and arterial blood flow, aiding in more accurate results. But if the patient cannot sit up, help in positioning them supine. Be alert and attentive as the healthcare provider selects and stabilizes the site in this position. Popular sites for ABG collection include the radial artery. Provide the healthcare provider with needed supplies and assist in positioning the patient's wrist for ease of access to the radial artery. Observe the Allen's test, as we discussed, for adequacy of collateral circulation. We might need to use a brachial artery. If the radial site isn't viable, assist the healthcare provider in accessing the brachial artery. Be knowledgeable of this anatomical risks, as it's near nerves and large blood vessels. We also might use a femoral artery. In critical cases, be prepared for femoral artery access. This site has high complication risks. That's why your adept assistance and keen observation is needed. Verification steps before the puncture include, once again, making sure that Allen's test has been performed and is adequate for a radial site. And then we need to support the healthcare provider in assessing pulse strength and regularity at the selected site. A weak or irregular pulse may necessitate a change in site. We also need to offer assistance to the healthcare provider in inspecting the skin for any signs of infection or bruising that could contraindicate the site. Finally, before the healthcare provider begins, help in confirming the patient's comfort and make sure that final consent has been obtained. Your role in keeping the patient informed and at ease is pivotal. Nursing interventions intra procedure. While the healthcare provider is performing the arterial puncture for ABG collection, your role is pivotal in ensuring a smooth procedure. Your duties focus on maintaining sterility, facilitating communication, and coordinating patient care immediately before, during, and after the procedure. Make sure the healthcare provider performing the ABG adheres to strict hand hygiene protocols. As a nurse, you should also wear appropriate PPE to maintain a sterile environment. Assist the healthcare provider in prepping the puncture site. Hand them any necessary antiseptic wipes or solution, and be prepared to provide sterile gauze or cotton balls. Maintain an ongoing dialogue with the patient to reduce anxiety and inform them of each step the healthcare provider is taking. Although you won't be the one performing the procedure, be attentive to the patient's comfort levels before and after the puncture and make any necessary adjustments for pain management. Monitor vital signs pre and post procedure. Alert the healthcare provider to any significant changes that could indicate complications. Be ready to assist the healthcare provider in ensuring that the blood sample is collected into a heparinized syringe without air bubbles or other contaminants. Should the sample need to be transported, make sure it is placed in an ice slurry promptly. Confirm that the healthcare provider avoids freezing the sample, which could compromise its quality. Double check the healthcare provider's labeling of the sample with the patient's information, date, and time of collection. Verify this against the patient's chart for accuracy. And after the healthcare provider secures the sample, apply pressure to the puncture site with sterile gauze to minimize bleeding. Be vigilant for any signs of complication like hematoma, excessive bleeding, or localized infection post procedure. Due to the invasive nature of an ABG, you need to make sure that you are performing all safety measures and maintaining asepsis to ensure that all needed supplies are within arm's reach for the healthcare provider performing the ABG. The setup should include a sharps disposal container, sterile syringes, antiseptic solutions, and biohazard waste bags. If you're in an isolation room or if the patient has known infections, ensure that both you and the healthcare provider adhere to the room's specific isolation precautions, such as donning additional personal protective equipment. Hold the patient's arm steady if necessary, while maintaining a safe distance to minimize the risk of accidental needle stick injuries. Keep the antiseptic wipes and sterile gauze close at hand. Act as a conduit between the patient and the healthcare provider. Keep the patient informed of what to expect during each step and monitor their comfort and anxiety levels. Ensure that puncture resistant sharp container is within immediate reach of the healthcare provider. This prevents cross contamination and accidental needle stick injuries. Double confirm the patient's identity and the test orders. This second level of verification minimizes the risk of medical errors. Be prepared to apply pressure with a sterile gauze immediately after the healthcare provider completes the arterial puncture. Monitor the site for any signs of complication like excessive bleeding or hematoma. Record the procedure's details such as time, healthcare provider, any complications or patient reactions. And remember, this documentation should also include the results of any pre-procedure tests like the Allen's test. Nursing interventions post-procedure. Once the ABG has been collected by the healthcare provider, your responsibilities as a nurse transition into critical aftercare. The following steps are crucial for ensuring patient safety and data accuracy in the immediate post procedure phase. Immediate hemostasis. The first priority is to achieve hemostasis. Use a sterile gauze pad to apply pressure to the puncture site until bleeding stops. Usually, this requires 3 to 5 minutes of pressure. You're effectively minimizing the risk of a hematoma. Once hemostasis is confirmed, secure a gauze pad with adhesive tape over the site. This acts as a secondary measure against bleeding and potential infection. Reassess vital signs and compare them to the baseline values you documented before the procedure. Any significant changes may indicate complications and require prompt intervention. Continuously observe the puncture site for signs of hematoma, infection, or excessive bleeding. Immediate action is required if complications are evident. Make note of the patient's condition and any interventions you have performed in the medical record. This includes documenting any changes in vital signs and the appearance of the puncture site. Assess the patient's level of discomfort. Although ABGs can be painful, timely application of an ice pack can help to relieve some of this discomfort. Keep the patient informed of the next steps, such as how long it will take for results to be available. This helps to manage patient anxiety. Double check the labeling of the sample to ensure it's accurate and ready for transport to the lab. Although you didn't draw the ABG, you may be responsible for its transport. If immediate analysis is not possible, confirm that the sample is properly stored, typically in an ice slurry, to maintain its integrity. Monitoring for complications is a vital part of your post procedure responsibilities. Quick identification and appropriate interventions can drastically improve patient outcomes. Routinely inspect the puncture site for swelling or discoloration that suggests hematoma formation. Timely identification allows for immediate intervention, such as applying more pressure or using a cold pack. Look for signs of localized infection like increased redness, warmth, or purulent discharge. If these signs are present, alert the medical provider and prepare for interventions such as antibiotic therapy. Be aware of symptoms like dizziness, nausea, or fainting, as these could be signs of a vasovagal reaction. Having the patient lay down and elevating their legs can improve blood flow to the brain. Particularly in patients with compromised circulation, monitor for signs of ischemia, like pallor, coldness, or a decrease in pulse strength distal to the puncture site. Keep a close eye on vital signs, particularly blood pressure and pulse oximetry, to catch any changes that may indicate a complication. If available, review the ABG results as soon as they come in for any abnormalities that may necessitate clinical intervention. Although you didn't draw the sample, your understanding of the values will help to guide future care. Document any signs of complications, interventions performed, and changes in patient status in a detailed manner. Maintain strong communication with the medical team, particularly if you identify any complications. Quick updates facilitate rapid decision making. Keep the patient informed of their condition and any necessary interventions. This will help to alleviate anxiety and encourage compliance with treatment. Client education about the procedure. Education is a cornerstone of patient centered care. In the context of ABGs, providing comprehensive yet understandable information to the client not only aids in informed consent, but also helps to manage anxiety and expectations. Clearly articulate the medical necessity for an ABG test, be it to assess oxygen and carbon dioxide levels, acid base balance, or any other critical clinical indicators. Inform the client that they may feel a sharp momentary sting during the arterial puncture. Reassure them that this discomfort is typically brief. Explain that the entire process usually only takes a few minutes, from preparation to completion. Describe how they will need to be positioned for optimal arterial access, depending on their medical condition. Emphasize the importance of the test in guiding their treatment plan and monitoring their physiological status. And disclose potential complications such as infection, hematoma, and rare instances of nerve damage. Stress that these are uncommon and that healthcare providers take multiple steps to minimize risks. Share what will happen immediately after the test, such as the application of pressure to minimize bleeding and the potential for short term monitoring, and advise them on the typical time frame for receiving results and how those results will influence their treatment. Make sure to open the floor for any questions they might have. Ensure that they understand the procedure fully before they sign any consent forms. Employ the teach back method to confirm that the client comprehends the information. Ask them to summarize what they've learned in their own words. Record the educational session in the patient's chart, noting that you've covered all key points and that the patient has had the opportunity to ask the provider any necessary questions. A well informed client is more likely to be cooperative and satisfied. It is the provider's duty to obtain informed consent. However, education does fall strictly within your scope of practice. Potential complications and nursing interventions. Complications can have serious repercussions if left unaddressed. Nurses are essential in the prompt identification and management of complications such as hematoma, infection, and arterial spasm during and after ABG collection. Your role extends from real time monitoring to clinical interventions and effective communication with the healthcare team. Be alert for signs like localized swelling, a growing lump, bruising, or skin discoloration around the puncture site. Tender areas are also a significant indicator. Elevate the limb immediately to reduce blood flow to the area, thus minimizing further swelling. Apply pressure with sterile gauze to control bleeding, but do so with caution to avoid exacerbating the hematoma. Measure the size and document the appearance of the hematoma every 30 minutes to an hour initially, and then as clinical judgment dictates. Capture any changes in digital photos if your facility's policy allows it. Consult with the healthcare provider for guidance on further interventions, like ultrasound to assess the severity. Relay any changes in size, color, or other characteristics through the proper channels immediately. Inspect the puncture site frequently for signs of infection, redness, increased warmth, pus, or worsening. If infection is suspected, clean the area with an antiseptic solution without scrubbing harshly to avoid spreading any infection. Reevaluate the site at least every 8 hours or more often based on severity and clinical guidelines. Make sure that you notify the healthcare provider immediately upon suspecting infection for any further orders, which may include antibiotics or a more rigorous cleaning protocol. You need to recognize symptoms such as pallor, coldness, and absence or decrease of pulse distal to the puncture site because these indicate an arterial spasm. Apply warm compresses cautiously to dilate the artery if permitted by the healthcare provider. Use pulse oximetry and tactile assessment to frequently monitor arterial blood flow. Keep an eye out for the reestablishment of normal color and warmth. Seek immediate medical intervention if spasm does not resolve very quickly or if ischemia is suspected. Treatment might involve medications like calcium channel blockers or surgical interventions. Remember, you play a pivotal role in identifying and managing complications, and your proactivity can prevent the escalation of minor issues into major medical concerns. Unforeseen complications can rapidly escalate into crises that demand immediate intervention. This section outlines comprehensive step by step guidance for handling the most common crises in ABG collection: air embolism and hemorrhage. For an air embolism, signs can develop suddenly and may include acute respiratory distress, cyanosis, confusion, or a drop in blood pressure and heart rate. Monitor the patient's vitals vigilantly right after ABG collection. Lay the patient on their left side and elevate their feet. This helps to prevent air from traveling towards the pulmonary circuit. Administer high flow oxygen through a non rebreather mask to improve oxygenation levels. Rapidly notify the attending physician, respiratory therapist, and the rapid response team. Be prepared to assist in emergency interventions like needle aspiration of air, which might be initiated by the medical team. Record the onset time of symptoms, nursing interventions performed, and the responses of the medical team. Update this in real time to facilitate immediate treatment choices. For hemorrhage, any excessive bleeding from the arterial puncture site or development of a large hematoma are key indicators. A sudden drop in hemoglobin or hematocrit levels should ring alarm bells. Apply pressure dressing to the puncture site and elevate the affected limb to minimize blood flow to the area. Check the patient's vitals and blood counts immediately. Contact the attending physician and possibly the hematologist for further direction. You may need to prepare for blood transfusion or surgical intervention depending on the severity of the hemorrhage. Accurately note the volume and characteristics of the blood loss, interventions initiated, and subsequent patient responses. Immediate and precise documentation is crucial for guiding further medical treatment. We've covered an extensive range of topics today that underline the indispensable role nurses play in the process of arterial blood gas studies, from pre procedure preparations to managing potential complications. As a nurse, you are instrumental in preparing patients for ABG collection. Your vigilance and monitoring can prevent or mitigate complications. Your actions set the stage for accurate ABG results and a safe patient experience. Your pre procedural steps ensure not only the accuracy of the ABG results, but also the patient's comfort and safety, from ensuring that the physician has provided informed consent to vital signs assessment. Each step carries significant clinical importance. You are the first line of defense in detecting early signs of complications like hematomas or arterial spasms. Rapid identification and intervention can often prevent a minor issue from escalating into a crisis. But as we discussed, complications can escalate quickly, so you must be adept in crisis management protocols for scenarios like air embolisms and hemorrhage. Timely coordinated action is vital. And finally, the responsibility to educate the patient about ABG procedures lies heavily with the nursing staff. A well informed patient is more likely to cooperate, and this reduces their anxiety levels while enhancing the accuracy of the results.